I'm now starting the recording. Okay. Here's a little overview of the things the things we're gonna talk about. First of all, as I said, facts and myths about depression. Then I'm gonna go over body focused repetitive behaviors really briefly because I think most of you are familiar with those. We're gonna talk about connections and differences between depression and BFRBs and the role of cognitive behavioral therapy. And actually, I forgot to mention in the beginning, this is going to be the first webinar in a series of 2 webinars covering the connections between depression and BFRBs. The next one is going to be more about distorted thinking patterns and their role for both disorders, but I'm gonna talk about that more. Okay. Facts and myths about depression. And at this point, we cannot really open a discussion, but I do want to encourage you for each of the thoughts that I present to just take a moment and think about it yourself. Think about whether that might be a fact or a myth or something in between, just so it's going to be easier to follow all the theory that I'm going to be presenting. Okay. Depression basically means being really sad all the time. So at this point, I want to encourage you to think about what you know about depression, and what symptoms do you think depression entails? Because it is one of the most talked about psychological disorders. Okay, so this one is kind of a myth and a fact. Actually, being sad is part of depression. It's one of the 3 main symptoms, but depression is much more and actually also can look very, very different in different people suffering from it. So according to the World Health Organization that classified depression in the ICD-10, there are 3 main symptoms that have to persist for at least 2 weeks on most of the days. And those are persistent sadness or low mood, as in our fact/myth. Loss of interest and enjoyment, meaning that activities that I once found satisfying or enjoyable all of a sudden don't bring me pleasure anymore. And reduced energy, increased fatigability, and diminished activity, meaning that all of a sudden things in my day-to-day life seem incredibly exhausting, and sometimes just getting out of bed seems almost impossible. We need at least one of those symptoms to be present. And then there's additional symptoms that we find in depression, just like reduced self-esteem and self-confidence, ideas of guilt and unworthiness, ideas or acts of self-harm or suicide, reduced concentration and attention. And then we have 3 somatic symptoms, which are more focused on the body than on the psyche. And those ones can always go in both directions. A person can feel agitated or slowed down in movements. A person can sleep more or less. And the person can have increased or decreased appetite. Yeah, so we see that depression is much more than just being sad, and you see different people might suffer from different of those symptoms. Let's look at the next one. Depression looks different across cultures. Again, giving you a few seconds to think. Now, this one is actually 100% a fact. Interestingly, because I just showed you standardized classification, a standardized classification of depression that we use all over the world. But although most parts of the world use either the ICD or the DSM, those classification systems for psychological disorders, we still see a lot of differences between different cultures. One of them is the prevalence of depression, meaning how many people suffer from depression at least once in their life. I mean, here we're talking about lifetime prevalence. And we see that depression is actually more common in high-income countries, such as New Zealand and the US, than in low to middle-income countries, such as, for example, the Lebanon and Mexico. This seems paradoxical or counterintuitive at first because a higher income might also mean a higher standard of living. But there's all kinds of theories why that might be the case. One is obviously that maybe in high income countries, more people actually seek help for their depression or have access to seeking help and diagnosis. And another point is that actually in high income countries, we have more income inequality, which is a factor that's promotes a wide variety of chronic conditions, including depression. And then there's also significant variation in the symptoms that people present with in different cultures. So I talked about those somatic symptoms such as sleep disturbances or fatigue / agitation. And those are actually more common in countries such as China, Japan, India, Latin America, and Africa than in more Western countries such as Europe and North America. One possible explanation for that might be that in Europe and North America, conceptually, there's a separation between body and mind. Whereas in China, Japan, India, Latin America, and Africa, the psyche and the way you feel is more connected to the body conceptually. Another difference in symptoms would be the expression of positive affect. So if we talk about depression, there are negative symptoms such as low mood and negative affect, but also we can see whether someone is depressed by the loss or lacking of positive affect. And we found that in Japan and some other Asian ethnic groups, such as Koreans, people participating in this very study displayed lower levels of positive affect than in other countries. This might be due to the fact that maybe the expression of positive affect is more inhibited in Japan than, for example, in North America due to the collectivist nature of the Japanese society, or maybe also cultural characteristics related to modesty. We also see variation in feelings of guilt. Feelings of guilt as a symptom of depression are more frequent in Europe and North America. This might be due to the fact that those countries are based on a culture bearing the Judeo-Christianic faith, which is a faith where guilt plays an important role. And this idea is also supported by the fact that symptoms of guilt have been going down, decreasing in the last 100 years, just as the importance of religion in Western cultures and Western societies. And lastly, we have differences in suicidality. So depression is actually more connected to suicidality in, again, Western countries. In non-Western countries, suicidality is more related to mental disorders such as PTSD, conduct disorder, and drug abuse. Yeah. So far on depression looks different across cultures. Now we have our last thought, which might be a fact or a myth. Eventually, you will just snap out of it. Here I want you to think about maybe people that you know that are suffering from depression. Most people know someone who's suffering from depression. Did they manage to live with their disorder? If yes, how? Did it just happen automatically? Does it come and go? Or did they seek therapy to improve their symptoms? Yeah. So here again, we have something in the middle between the fact and the myth. You don't always snap out of a depression automatically, although we talk about a depressive episode, which is something that might just go away. But people suffering from depression usually the way the depression is caused is usually based on many factors, and most of them are quite constant, such as biological factors. People suffering from depression usually find differences in their brain chemistry, imbalances in the neurotransmitters such as serotonin, norepinephrine, and dopamine. There's a genetic component, meaning that if I have someone in my family who suffers from depression, I have a higher chance of developing it myself. There are psychological factors such as negative thinking patterns that we're going to talk about, and personality traits, for example, perfectionism or a tendency towards self-criticism. There are tons of environmental factors that lead to depression breaking out, for example, stressful life events, early childhood trauma, chronic illness, substance abuse, and lack of relationships or social integration. And all of these factors that can lead to a depression don't just go away, right? They're always there. And that's why oftentimes therapy is necessary. And in terms of the course of depression, we also see there's a wide range of different possibilities. So you have people who just suffer from one depressive episode in their lives that goes away maybe faster with therapy or maybe just by itself. But you also have people who suffer from double depression or depressive episodes that recur, such as in graph B, not number B. You have dysthymic disorder, where you basically have depressive episodes that are subclinical but never go away. You have recurrent depressive disorder, where episodes come and go, but you never have a complete remission in between. There's such things as chronic major depression and major depression with incomplete remission. So in most cases, you won't just snap out of it, and therapy can really help you. Okay, thus far on depression. Very briefly on body-focused repetitive behaviors. Obviously, a lot of you are here because you signed up for an email list by our company Helping Minds that tries to help people suffering from skin picking and hair pulling. And BFRBs, or body-focused repetitive behaviors, is basically an umbrella term for those repetitive self-grooming behaviors that involve biting, pulling, picking, or scraping one's own hair, skin, lips, cheeks, or nails. They can lead to physical damage to the body and have been met with multiple unsuccessful attempts to stop or decrease the behavior. That's very important to notice because there's a lot of subclinical BFRBs, and for a BFRB to actually reach the classification of a clinical case means that a person has repeatedly tried to stop the behavior and also done significant damage to their body. And the most common BFRBs, as I said, are trichotillomania / hair pulling, dermatillomania or excoriation disorder, which means skin picking, and onychophagia, which means nail biting. Now, let's get to the point. How are those two connected? And how are they different? First of all, a significant part of the general population suffer from those disorders. Depression is more common, and with those numbers depicting the prevalence, meaning how common disorder is for a certain population, we always see a lot of variation, and different studies can bring different numbers. But if we look at several different studies, the average for depression for a person, the average part of the population who suffers from depression at least once in their life would be about 12%. And for BFRBs, it would be around 3%. Again, here I'm talking about clinical BFRBs. If we talk about subclinical BFRBs, people who once in their life engaged in skin picking or several times in their lives engaged in skin picking, hair pulling, or nail biting, then we talk about much higher numbers, around 60% even. In terms of prevalence, there's another similarity. Women have a higher likeliness to suffer from both disorders. This is even more significant for BFRBs. Here we have a ratio of 1 to 4, meaning for every 1 man suffering from BFRBs, we have 4 women. And for depression, it's 1 to 2, meaning for every man suffering from depression, we have 2 women. Or we find 2 women. Now the question is that really the prevalence? Is that the case? Or are there factors playing, kind of distorting those results? There are theories for both. Some people think that hormonal, social, or other factors lead to women actually really suffering from depression more often than men. But there's also the theory that men might be less likely to report depressive symptoms or seek help or complain about the symptoms. And also, depression can actually look different for men. With men, we sometimes find less of depressed mood and more irritability and aggression, emotion-wise. So it sometimes also presents differently in a way that therapists don't even know to recognize it. There's research on comorbidity, meaning depression and BFRBs co-occurring. And for the next few studies that I'm citing, those are all about trichotillomania. We unfortunately have much more research on trichotillomania, meaning hair pulling, than on the other BFRBs. So I'm sorry that this is specifically for trichotillomania, but I do think that we can generalize these results also to the other BFRBs. So I actually see that there is a significant amount of people suffering from, in this case, trichotillomania, and comorbid depression and or anxiety. Here we have a study with 530 adults from the US and Brazil from 2017, and we see that 11% of those suffer from comorbid depression, 18% comorbid anxiety, and 10% suffer from comorbid depression and anxiety. So around 20% of suffering from trichotillomania also suffer from depression at the same time. Which raises a question, what came first, the chicken or the egg? Or do you say the hen or the egg? Anyways, what came first? And we do not have an answer for that. I personally think it's much more likely that people first suffer from a BFRB and then develop a comorbid depression because of the symptoms of the BFRB. One study that hints towards this direction would be a study from 2009 in the US, again with trichotillomania, that focused on children aged 10 to 17. Here we also see a very, very high rate of those children reporting depressive symptoms in 45% of the cases and anxiety symptoms in 40% of the cases. And we see that older participants reported more symptoms of depression and anxiety, which means that we could develop a theory that those older participants that might have been suffering from BFRBs for a longer period of time already did develop depression because of the BFRBs. And finally, we see that when a BFRB and depression co-occur, that the depression is a big risk factor. In a study from the US and UK from 2023, researchers investigated the rate of suicidal ideation amongst people suffering from trichotillomania and found that 18.3% reported suicidal ideation, which is double the amount of the general population, and the one detail that differentiated those participants that suffered from suicidal ideation from those that didn't was mainly a co-occurring major depressive disorder, meaning participants that suffered from trichotillomania and depression at the same time reported much higher rates of suicidal ideation. Okay. Now we've gone over some differences and connections between BFRBs and depression. And at this point, I want to talk about the role of cognitive behavioral therapy, in short CBT, for both disorders. You might ask yourself why, because there's different therapeutical approaches, but actually CBT is a first-line treatment for both disorders, which means it's actually another similarity between the both of them. CBT, or a version of CBT that's called habit reversal training that we also include in our platform at Helping Minds, is the gold standard treatment for BFRBs. And CBT is also a first-line treatment for depression, amongst others. There's other therapeutical approaches that work, like interpersonal therapy and obviously medication, but CBT has also been found very, very helpful. I don't have enough time to go into the depths of CBT treatment, but to explain it in very simple terms would be to say that CBT is based on the assumption that thoughts and behaviors influence the way we feel. In addition to that, CBT is evidence-based, meaning it's grounded in sound academic research. First studies building the groundworks for CBT were done in the 1950s. And back then, an evidence-based approach was quite new, because most approaches were more based on philosophy, theory, or case studies. And to give you an example of the way CBT looks at difficult emotions and psychological disorders would be a very simple example, for example, like a person suffering from dog phobia, fear of dogs. So a CBT therapist would look at that person and think, okay, I want to make that person less afraid of dogs. How can I change their behavior and thoughts? Which behaviors and thoughts perpetuate or cause this anxiety? And then he might find that this person actually avoids contacts with dogs at all costs, doesn't visit friends with dogs, or changes the side of the road when they see a dog approaching. And they also might hold irrational thought patterns regarding dogs, such as unrealistic beliefs about how dangerous dogs are or how likely they are to bite you. And because they engage in those behaviors and hold those thoughts, they are afraid of dogs and can never make a corrective experience of actually approaching a dog and seeing that they don't always bite. So irrational thoughts and problematic behaviors are both the cause for the problem, but also an opportunity to solve the problem, if we put CBT very simply. Now let's look specifically at CBT for depression. Through the perspective of CBT, depression looks like a downward spiral. A person might develop a depressive mood, low mood, might be sad, maybe based on a life event. Sometimes there is no trigger at all. Sometimes it just happens. And then they might engage again in problematic behaviors, such as not leaving the house anymore, not seeing friends, not doing hobbies because they don't have any energy, or because they feel like nobody really wants to see them because they have feelings of low self-esteem. And then they might develop negative thoughts about themselves, like, I can't even manage to do the simple household chores, I'm not going out, my friends are not even reaching out to see what's going on. And those will lead to more negative emotions. And then the spiral will just go on and on if we don't do anything about it. And what we want to do in CBT is turn this downward spiral into an upward spiral. And interventions that help us do that would be, for example, activity scheduling, which would mean to create a detailed plan of activities for a person, in the best case, every day, that are pleasurable or give the person a feeling of accomplishment or self-efficacy. Activities where they reward themselves at the end of the day if they did them, just to get, you know, the activity level up and to create positive emotions. And then in order to challenge irrational thoughts, we would advise a patient to to keep a thought journal and try to be aware of the thoughts that come up, and then challenge irrational thoughts in therapy. And we're going to talk about those irrational thoughts very briefly today, but there's going to be a whole other webinar next month only about those irrational thoughts, because that's actually very interesting. CBT for BFRBs also has this kind of like awareness element where patients are advised to create awareness towards their triggers, situations, and emotions that precede BFRBs. And then we have two behavioral elements. One of them is stimulus control, meaning modifying a person's environment to minimize triggers that lead to picking or pulling behavior. And then we have habit reversal training, which I talked about before, which we do at Helping Minds. It's the gold standard for BFRBs, and it means that we want to implement competing responses to the picking or pulling behavior that are incompatible with the picking or pulling and also don't hurt a person's body, don't create any damage. And to do that, we need the awareness, right? We need to be aware of the fact, okay, now I have the urge to pick or pull, in order to be conscious and make a different decision and use the competing response. However, in addition to this, to those behavior components, we also have cognitive components in BFRBs. People suffering from BFRBs also tend to develop irrational thoughts about themselves, about their behavior, that can maintain or even worsen disorder. So if we want to look at the overlap between CBT treatment of depression and BFRBs, we see that both have an element of creating awareness for difficult behaviors and thoughts, and then an element of challenging those irrational thoughts, or those thoughts that in the long term maintain the disorder. Here I have two examples of such thoughts. First thought that a person with a BFRB might think, or specifically nail biting, is either I quit nail biting entirely, or I always be a nervous wreck forever. And then I have a typical thought for a person suffering from depression. If I make one mistake at work, I will ruin everything and prove that I'm a total failure. And at this point, again, I want to encourage you to take a moment and think about those two thoughts, and think about how they might influence a person's behavior or emotions, and whether there might be a problem with those two thoughts, and whether they might have something in common. Okay. Basically that was yeah. I mean, I already called them a rational thought pattern, so that was kind of giving it away. We also call those cognitive distortions, which means that they might not be completely wrong, but they're definitely exaggerated, irrational, or distorted. And they make people perceive themselves, their environment, and their future in a distorted, inaccurate way. And the two thoughts that I'm listing here, sorry, there's different categories of these cognitive distortions, and the category I used here is called all or nothing thinking or black and white thinking, which means that we see situations in extremes, which is what the two thoughts have in common. And the person thinking either I quit nail biting entirely or I'll always be a nervous wreck forever might have a really hard time dealing with relapse or small steps in therapy. And relapse is a big part of therapy. If I, for example, quit nail biting and then a week later engage in nail biting and think, okay, wow, I'm now going to be a nervous wreck forever. This didn't work. I'm just going to give up. Might never be able to manage their nail biting. They might also experience low self-efficacy, have less motivation to work on changing their patterns, and will also have a higher risk of developing comorbid depression. A person thinking to themselves, if I make one mistake at work, I will ruin everything and prove that I'm a total failure, will likely experience more negative emotions, will have lower self-esteem, and will be discouraged more easily at work, which might even make it a self-fulfilling prophecy. And now maybe because everyone listening here is looking at these thoughts, maybe you realize those thoughts are exaggerated and we can challenge them, but that's because you looked at those thoughts in a conscious way, right? And in our day-to-day lives, we don't question our thoughts. The thoughts come up and we can sometimes automatically just believe them or act upon them. And that's why creating this awareness and challenging them actively can make such a big difference. Okay, in conclusion, we went over facts and myths about depression today. We learned that depression can look very different for different people because there is a wide variety of different symptoms and that everyone suffers from the same symptoms. And even the symptoms themselves can express themselves differently from person to person. And also we have a lot of differences between different cultures. In addition to that, we saw that depression will not just automatically go away, at least not in most of the cases. There is different courses of depression and there are underlying chronic factors that if we don't work on them, we will always have a higher risk of experiencing depressive episodes. We looked at some connections between depression and BFRBs. We saw that both of them are affect a significant part of the population. And we saw that women are more affected than men and that they actually co-occur frequently. And then we looked at the role of CBT because CBT is a first-line treatment for both disorders. And we saw that there are actually therapeutic elements that can be useful for BFRBs as well as depression. Specifically, being aware of and challenging irrational thought patterns. As we say, you don't have to believe everything you think. And those irrational thought patterns actually are a critical factor that might maintain or even worsen a BFRB or depression, but also give the opportunity to treat those disorders and to cope better. And that's something that we're going to talk about in more depth next month. that was my presentation for today. At this point, I want to encourage you to think whether you have any questions at the end or any comments, and I'm gonna now open the Q&A window and see. Okay, you could all hear it. That's perfect. There is one question. I don't know exactly what it refers to. Just to clarify, this is for adults. Is there info on teens or kids? If the person that asked that question could just clarify what they're referring to, then I'm going to try to answer. Is someone necessarily emotionally dysregulated each time they engage in a BFRB? No, that's a great question. And this is actually a myth that BFRB has to be some way of regulating negative emotions, but it's not true. We also see automatic pulling or picking behavior that is completely unconscious. Sometimes we pick or pull just because we always do that in a certain situation. And sometimes we pick or pull because we're bored. It can help regulate emotion, but it doesn't have to. Another question, what studies or information do you have on the overlap of BFRBs with neurodiversity and dopamine regulation issues, such as with ADHD and autism? Hmm. Let me think. For autism, I don't know any studies. I know that for autism, some kind of repetitive behavior that also sometimes serves to calm you down is part of the symptoms, right? Some people suffering from autism might what do you call this? You know, do repetitive movements with their arms, might clap on surfaces and stuff like that. So I'm guessing it would be really difficult to conceptually differentiate between those behaviors. Would be interesting to check if there are any studies on that. If you could, because this is from an anonymous attendee, if you want me to look into that, you can shoot me an email. My email address is right there, and I'm gonna try to check. Same goes for ADHD. I don't know any studies that, but I'm guessing there might be some overlap between ADHD and BFRBs. Mm. You've explained similarities between CBT and depression, but the link wasn't really there. Is there more you can say about theories for the actual link or mechanism? Like, is skin picking a channel for releasing nervous energy from our anxiety? I'm guessing you meant similarities between BFRBs and depression, not CBT and depression, because CBT is a treatment for depression. And the link is actually we don't know exactly why they are connected, right? There are several theories. One theory might be that a person is suffering from a BFRB, and then those symptoms create negative effect and feelings of low self-esteem or things like that, and that might create the depression. Um, also the theory of skin picking being a channel for releasing nervous energy from anxiety makes a lot of sense. Unfortunately, we don't have research showing which of those theories are right. We don't even know if the BFRB comes first or the depression. Can you redefine habit reversal training or go back to that slide? Actually, just for you to know, on our YouTube channel, we have several complete webinars on habit reversal training, where you can get comprehensive explanations of how it works. But basically, what we try to do is in habit reversal training is to be aware of the BFRB, of the repetitive behavior, whether it's pulling, picking, or biting. And then we try to find a competitive behavior. Another behavior is something that I'm doing with my hands or my mouth that is that makes me not be able anymore to do the original behavior, the self-harming behavior is more healthy and also sometimes more socially accepted. How likely is it for trichotillomania to be passed down genetically? I don't know. I don't have any specific research on that, but I can tell you that I did not stumble upon the mental disorder yet that does not have a genetic factor. You always have a higher chance to develop a certain mental disorder if you have relatives that have the same. Is there one antidepressant anxiety med that has been found to be more effective than others? More effective for depression, I'm guessing, because for BFRBs, we know there's no medication proven to be effective yet. But we have a lot of antidepressant medications, and to be perfectly honest, there's different subgroups like selective serotonin reuptake inhibitors like SSRIs and different groups in terms of on which neurotransmitters they act. And there are certain medications that are prescribed more frequently because they have found to help a wider range of patients. It also really depends on which symptoms you have. Like, for example, if you have problem sleeping, then a certain medication might work better than another one, or if you feel agitated or fatigued. And mostly psychiatrists, which I am not a psychiatrist, so you can always question my input on medication, kind of work based also on experience, because we cannot measure how neurotransmitters are present in the brain. We usually just give the medication. Again, not me, I don't give the medication, and then see what works and what doesn't, and that's also how the studies work. What are some in the moment strategies for cognitive restructuring? That's something that I'm really going to talk about next month. But mostly what we do is we want to try to catch an irrational thought when it occurs. That's the most important part. It's very hard. Then realize why it might be irrational and ask ourselves if there is any other way I can think about the current situation that might be more helpful for me. For example, if I think, oh, I just relapsed with my nail biting, I'm never going to get out of this disorder, then I might produce a different, more helpful thought like relapse is normal. Everyone relapses. It's very important for me now to not lose motivation and think about different ways that I can get back on track. Yeah, do you know of any medications or supplements that have been studied to help trick? No, there is no medication or supplements that have been proven to help with trichotillomania. Watching the time, we still have some time for some more questions. A strange component of my skin picking for me is that I actually believe that I am making my skin better because if I scratch off the raised parts, it will heal over smoother and I can cover it easier with makeup. I am afraid if I give it up, I will feel panicked. So even though I know I am making it take longer to heal, I feel like it will be easier during the process. And I can't stop. So it doesn't seem like a bad behavior to me, even though I logically know it is. It's so hard. It is really hard. First of all, it's really hard. It's really hard to give up automatic behaviors, right? I always tell my clients when they come to me and then they've been suffering, from a certain behavior for 5 years and expect from themselves or from me that we solve this problem within a few weeks. Like, no, you've built this behavior for a really long time and you have to be patient with yourself. You have to be patient with yourself. Obviously, if you kind of make yourself think that the skin picking will help you, you have a much you have less motivation to change, right? And I also, this might be a little bit controversial. I think if a certain disorder doesn't create a lot of suffering for you, then you don't need to change it, right? You only have to change it if you really suffer. But if you do want to change it, then I would maybe make myself a list why the skin picking is bad. So you have that one present when you do it again, and also a list why this logic of actually making it better by picking why this might be faulty. So when it happens, you can practice, thinking about the skin picking in a different way. Is knuckle cracking a BFRB? I understand some may not consider it to be a BFRB, but I crack my joints all the time. I'm always cracking my bones from every part of my body, knees, toes, arms, wrists, fingers, legs, and quite compulsively so that it interferes with my daily activities. It's not just a bad habit for me. Thanks so much. I don't know if it meets the well, it would depend if it creates some damage physically for you. Um, the cracking. So I'm not sure if I would categorize it as a BFRB, but if you feel like you suffer from it because it takes considerable time out of your day, then maybe it doesn't really matter if it's a BFRB. You might still profit from habit reversal training if you feel, and that's really important, right? Because this is a compulsion. If you do it because you feel like this urge builds up inside of you, and if you don't do it, you're gonna get really tense or nervous or whatever. Or if you just do it automatically and always just notice afterwards, then habit reversal training might be good for you. If, for example, the compulsion is triggered um, by a feeling like a sneeze or something like before a sneeze, then it might also be a tic disorder. And if it's triggered by a thought, then it might be OCD. But if it's a tic disorder and if you have an urge like if in an BFRB, then you might profit from habit reversal training, no matter how we define it. Have there been any studies on how self-care routines can help combat BFRB habits? This is really hard to answer because self-care is such a broad term. But if the result of the self-care would be to be more relaxed and at ease, then it might also combat BFRB. But in terms of knowing specific studies, we would have to define self-care more specifically. Probably the same for PTSD. Whether there is comorbidity between PTSD and depression, might be. It's not a common combination, like PTSD and BFRBs, right? PTSD and depression obviously is very common. PTSD and substance abuse or anxiety is very common. PTSD and eating disorders is common. PTSD and borderline personality disorder is common. PTSD and BFRBs, there might be an overlap, but it's not one of the more common combinations that I know of. Any suggestions for those of us who have tried many times and many methods to address BFRBs and have not been successful? That's also a very, very broad question, because I would have to, see what did you try? At which point did you find that whatever you tried didn't help you? I mean, there are non-responders. There are people who have BFRBs and just cannot stop doing it. Like it's an illusion to think that everyone can treat their BFRB. We know that habit reversal training is the most effective way to do it. And we also know that it's something that takes you have to invest a lot of time and effort and stick to it, even if you relapse, even if it's hard, even if there's ups and downs. So obviously there are people for who HRT habit reversal training doesn't work, but there's also those who kind of like drop out of the process because it's too difficult. Um, if if that's something that you tried specifically, then I also want to advise you to try more mindfulness or meditation based approaches. Those can also really help. And maybe try a different therapist. Having the right therapist is also very important. Or try our program. We also have therapists. Okay. I'm not sure I'm gonna be able to go over all of the questions. I'm trying to be brief now. One more question. Any input on research around psychedelic therapies and BFRBs? I'm sorry, I don't know any. Psychedelic therapies are tried out right now for PTSD and depression and anxiety. I don't know about BFRBs. I also not sure if that would make sense to me, because I think psychedelic therapies are more there to reach deeper levels of consciousness and past traumatic events that we haven't processed, at least. And I'm not an expert on psychedelic therapies either, but and those are, and that's by the same person who said that she tried a lot of things and that they haven't worked. I'm not an expert on it, so I don't want to just say it doesn't work. You can look into it if you find someone who really knows it, but also depends on which country you live in, whether this kind of therapy is even legal. Do you have advice which movements, gestures are good for HRT for skin picking? There's lots of different movements. I could give you, I could go through a list now verbally, but you can actually just maybe look that up on Google, or write me an email, and then I can write you a list later. I was diagnosed with bipolar depression in my 40s and prescribed antipsychotics, risperidone to be precise. When I was released from the hospital, I started to pull my hair and to suffer from BFRBs. Is this common? Not that I know of. But I'm not a psychiatrist, so I'm not the right person to ask. I'm sorry. Um, Whether it's common or not, when you take medication, specifically antipsychotics, which usually have some kind of side effect, you always have to just, evaluate, the benefit and the cost. And if you say the BFRB is too high a cost for me, then you might want to try a different medication and see if it helps with the BFRB. I have depression, anxiety, PTSD, and trichotillomania, and I can say that being properly medicated and in therapy to help with those things allows me to work on the BFRB with therapy. First of all, depression, anxiety, PTSD, and trichotillomania is a lot. So I don't know, it's really touching for me to see that you're, dealing with those things, seeking therapy and taking medication. And I'm so happy to hear that it allows you to work on the BFRB and keep on going like that. That's a lot to deal with. That's so great to hear. Um, is there a website or resource to find a psychiatrist who helps those with BFRBs? Um, that really depends where you are. So, like, because you guys are from all kinds of different countries. I don't know of one, but we are working at Helping Minds. We are working on trying to cooperate with psychiatrists in the future, to support therapy with medication, but that might also be only for people who suffer from another disorder in addition to the BFRBs, because as I said, there's no medication yet that's been proven helpful with BFRBs scientifically. If yoga can be helpful. Again, I think everything that releases stress might also be helpful for a BFRB. It's not it's not the gold standard treatment, but I'm sure if yoga helps you to be more at ease and less stressed, then it might have a positive effect on your picking and pulling behavior. You also might, during yoga practice, if the urge comes up and you manage to stick with your breath and your movement, to practice not engaging in the urge during yoga. Have you heard anybody discussing the NAC supplement? There's a few studies on it, but there's not sufficient proof yet that it's helpful for trichotillomania or skin picking, but I would stay on it. Like, there's research is continuing to be done on NACs. Is there a possibility to check the genetic predisposition? Depending on which disorder you mean, BFRBs or depression. You mean in a person. In a person, there are studies on, again, it depends on the BFRB or depression. For depressions, we have specific genes identified that might lead to depression. Is there, you know what? I don't know if you can really check it. I didn't hear about the possibility of a person really checking it. I can look into that. If you write me an email, I'm gonna check that. That's a really good question. Again, about the NAC, I read a study that found that it helped with BFRBs. It's not sufficient research yet. Depending on which side effect it might give you, you can try it with a psychiatrist who wants to prescribe it. But I'm not a psychiatrist, so I'm not the best person to ask. 5 years is not so much. I have had the problem for 40 years, and even though it's gone on for so long, it is only now I am able to deal with it without the shame. And I hadn't doing what I need to do to look it in the face. Wow, that's so beautiful. I'm so happy. It's never too late. And even if you've suffered from it for 40 years, you can still change it, right? It's just, it takes a lot of effort, and there's really no shame to be had about it. I'm so happy that you're working on it now. I have been suffering from trich for 6 years now. I just relapsed and I'm discouraged. Wow. Yeah, I can understand. I cannot afford therapy right now. So what are some realistic things I can do to try and reverse my own habits at home? Is the thought journal something that would help me with this? First of all, just remember relapse is normal. Most people have some moment where they relapse with whatever it is, BFRBs or other mental disorders or behavioral problems. You might want to think about our program, which is cheaper than one-on-one therapy. and still accompanied by a therapist, but it still is a certain cost. It's a $260 per month subscription. We also have webinars and other resources that are for free. So please feel free to check out our website. And then also sometimes there are self-help books. Specifically try to look for habit reversal training that you can buy, and then they kind of like try to help guide you through like the therapy process. Oh man, I'm not going to be able to do all the questions. I want to set myself a time limit. I'm going to do until 8 and 10 minutes. And if there's any question that's really urgent, then please send me an email and I'll try to answer. The app asks me to log the thoughts I was thinking at the time. When I pick in front of the mirror, it feels mindless, like a trance. How should I approach the what thoughts were you thinking from? Should I focus on what I was thinking beforehand or after? That would be automatic picking, which is oftentimes not related to a thought. I would focus on the thought that you were thinking beforehand. What is the difference between a tic disorder and the BFRB? Very good question. So there are certain movements that are more typical for tics and certain movements that are more typical for BFRBs. Most tics are not self-harming. Tics usually people start developing tics in their childhood mostly, and they start in the facial area with like blinking tics and like all kinds of things in your face, and then they can grow and move to different areas, and also you can develop vocal tics like in Tourette's, where you have vocal and motoric tics. So that would be a difference. And another difference is how you feel before you do the tic or the BFRB. Before you do a tic, the best way that clients describe it is like the feeling like an inner itch, like before a sneeze. And then when you do it, it gives you this feeling of release, and you can delay it, but it's really hard to not do it. And that's different from a BFRB, but the treatment is the same. You also treat tic disorders with habit reversal training, but there's also medications that help with tic disorders. And if it's a severe tic disorder like Tourette's, then you need medication. Any correlation between BFRBs and OCD? Very quickly, we have a complete webinar on that. Please check YouTube, and there's a lot of interesting facts there. Is there any study as to why people select certain locations on their body to pick, lips versus hair versus skin? I don't know of such a study, but I do think there are sometimes certain locations that people pick in terms of like which parts of their body they focus on in their day-to-day life. Probably those factors play a high role when the BFRB is first developed. I don't know if there's any studies looking into that. I don't know any. Caffeine is a correlation, right? I don't know. Is caffeine a correlation? I don't know. Haven't heard of that. Besides CBT, what therapies are being used frequently for BFRBs? Not a lot. You have mindfulness-based therapies. You have a lot of therapies that are used because people are not specialists and don't really know how to treat BFRBs. There's approaches that are also CBT-based, where you try to just completely resist the urge to pick or pull. But CBT is the one that's been found the most effective. About 8 months ago, I received the Trick Stop newsletter. It described the supplement NAC, and I tried it and combined it with habit reversal training, and it works. I have not pulled my hair in 8 months. Thank you so much, Trick Stop. Well, that's also very interesting for everyone asking about the NAC. So here we have an example, a case study of a person that really profited from the medication in addition to CBT. That's great. I'm so happy to hear. How do I listen to and watch this session? My internet went out in mid-session. This is going to be uploaded to our YouTube channels. Any correlation between BFRBs and obsessive compulsive disorder? There are correlations, and again, there's a complete webinar on it. Wow, I'm actually managing to answer all the questions. Last question. A study about the location would be interesting because I do it without thought, and the straightness of the line with which I pull my hair is really odd. I don't think I could pull a straight line like that if I actually try to do it consciously. Very interesting. So there is something subconsciously guiding you to pull in this straight line. Yeah, I also think I'm gonna try to look into. I'm gonna try to check if there is any studies. It might be very interesting, not only the way where you pick, but also as you described, the way you pick. For some people, it's not only picking. For some people, it's a whole chain, playing with the hair, picking it, eating it, or feeling it in your mouth, whatever. It's really complex, and there might be some common factors defining where and how you do it. Okay, great. Now I'm gonna close the chat before there's any more questions because I can't answer them anymore. Thank you so much for attending. Please check out our website and please check us out on our social channels. If you have any more questions, please don't hesitate to write an email. And wherever you are, I hope you have a nice evening and a nice day. And tune in next month for the next webinar.